then there was increased job satisfaction and a positive information available. In Victoria, the health system benefits were noted that there was a 0.77 day reduction in the length of stay and an associated reduction of cost per admission of $726. In Carlin, the scope and implementation of this is going to commence through the RA Emergency Department for general medicine admissions. We have approval to conduct this until the 30th of June next year. And we are anticipating that our pharmacists, once credentialed, will be able to conduct approximately 5 admissions per day. We'll be staffing this initially Monday to Friday in our normal business hours, 8:45 to 5 p.m, and hope to expand to a 7-day service from 8 a.m. to 10 p.m. from next year, which will incorporate 3 shifts of pharmacists. Of course, we need to contribute to more credentialed pharmacists to be able to achieve that. And the total FTE we have in the emergency department will be for both regular pharmacist activities as well as a partner charting model. So this presentation, just briefly to let you know that you might start to see some of these activities happening. General medicine colleagues are aware and supportive, and I'm very excited that we've started credentialing 2 pharmacists as of yesterday, and we hope that you will begin to see some of the benefits and flow-on effects. So Carlin Pharmacy, very happy to answer any questions you may have as we proceed with this, and hope to present to you our results in due course. Thank you.
Thank you very much, Caroline. We might keep moving. Is there any questions in the room specifically for pharmacy today? And people online, Caroline, are you hanging around for a little while? You might, if there's any questions that come up, I might throw them back to you, but we'll continue on with our main presentation. So I might invite Peter Subramanian to come up and introduce our speaker today. Thank you.
Thank you. I just want to congratulate Caroline for, it's quite a significant improvement in terms of medication error, and certainly an initiative worth supporting. So thank you for your work on that. There are 3 elements of success of any clinical workforce. It's a united workforce, it's a high quality leadership team, and a high trust between workforce and the leadership teams that we lead. So creatively and effectively responding to challenges, and that's an example of that, in an uncertain environment does require us to understand what teamwork means. We create teams in all our programs and across the organization. We build processes, and again, I want to reference that you built a process that achieves the aims of the team, but it functions best when we value teamwork. Part of being an effective team is that we show an ability to support stable leadership. And that's non-negotiable if we are interested in the primary focus being the success of any healthcare organization, which at the end of the day is patient care. Effective teamwork is sustained not just when good leadership is supported, but good leadership in turn enacts policies based on sound principles and evidence, with consensus being arrived at by all stakeholders. Teams and leaders are human, and as such, we are subject to the same elements of human interactions. Our success is our ability to harness these human factors to the benefit of our fundamental mission, which is the most effective care of our patients. Ben Starnes, Ben Starnes is the professor, chief of the Division of Vascular Surgery, and the chair for the Department of Surgery at the University of Washington in Seattle. Ben is the Alexander Whitehill Close Endowed Chair of Vascular Surgery at UW. He spends most of his time now clinically at Harborview Medical Center, which is one of the nation's leading level 1 trauma center. He has seen active duty for 15 years and has a distinguished military service. His experience in trauma, combat, and more recently in leading his team to maintain its function during the pandemic is a source of learning. And Central Adelaide Local Healthcare Network is very pleased for the opportunity for us to hear from Ben and to interact with him as we have been for the last 2 days and another day. Without further ado, I'd like to invite Ben.
Thank you, Peter. And for those of you joining us online, welcome. What we just heard was a brief presentation of a quality improvement. I haven't seen a number needed to treat that low in 2 decades, 1.6, to make sure that that was, here you go, that was, that's effective. I mean, that's as good as it gets. Let me just get out of these slides here and pull my presentation up. So I'll start by saying some of you in the room may have witnessed Formula One racing as a model of efficiency. And what you see there are, if you ever have looked at a Formula One car being serviced at a pit stop, you see the car come in, you see all the workers come in, they take the tires off, they replace the tires, they fuel the gas tank, they change the oil, and off the car goes again. And that takes about 8 seconds. Wouldn't it be great if we could do that with healthcare, where we could modify all the human factors such that we were so efficient and there was never a mistake made? Contrast that image in your head with this scene right here, which is a scene on the battlefield where you have a critically injured patient that you're trying desperately to save the life of. And what could go wrong? Well, there's just about everything that could go wrong in that scenario. These are my disclosures for this particular talk. This is a talk on human factors. In 2014, I was privileged to work with this group of people, Douglas Weigeman in particular, and Ken Catchpole, who were human factors researchers at Cedars-Sinai Medical Center. We published this paper in the World Journal of Surgery entitled Flow Disruptions During Trauma Care. Just to re-familiarize you with what a flow disruption is. A flow disruption is a deviation from the progression of care that compromises safety or efficiency or quality. The frequency and specific causes of flow disruptions are really poorly defined, or we thought they were, in modern trauma care. And we felt the need to identify and quantify the rate of various flow disruptions during various phases of trauma care. They asked me to be a part of this NIH-funded group because some of the ultimate flow disruptions in care can be a beeper going off, a phone ringing in the operating room, someone coming up to you while you're operating and asking you a question, a bomb exploding in Iraq, which causes you a percussion effect on your chest. These are all distractions to the task at hand, if you will. We trained 7 observers at a level 1 trauma center over a 2-month period of time. And these observers recorded details using a validated data collection tool during certain phases of care in the trauma bay, in the imaging room, and in the operating room. They recorded work system variables to include breakdown in communication or coordination, environmental distractions, equipment issues, or patient factors. 86 trauma cases were observed over a 2-month period of time. There were 72 low-level and 14 high-level activations. I'm going to describe to you what that is in a second. But overall, there were 1,759 flow disruptions recorded. There were 20 per case. This is the first time this kind of research had ever been done. I want to show you what a critical trauma activation is. So What you see here is a very small table. I don't expect you to be able to read this, but you have critical trauma activation, which is trauma 100, and then trauma activation, which is trauma 200. But a critical trauma activation had the following characteristics: adults with a systolic blood pressure less than 90, children with trauma and a blood pressure less than 70, respiratory compromise, gunshot wounds to the neck, chest, or torso, basically sick patients. You guys probably have your own code to qualify trauma patients, but this was a critical trauma activation versus non-critical. And that's why I say there were 72 low-level and 14 high-level activations. I want to take some time to go through how we define flow disruptions and give you specific examples, hopefully so that it'll cue in your mind ideas of how to improve quality for the care of your patients. So, for instance, a flow disruption in communication would be defined as a disruption that involved the verbal transition of information between at least two team members. An example is a nurse asked the trauma resident to speak up because too many people were talking during the code. Interesting. Coordination, disruptions that involve the interaction with some piece of equipment, as well as at least one other team member. An example being another patient was in the CT scanner when the trauma patient arrived to the CT scanner. That is a problem with coordination and a flow disruption. So these are the types of flow disruptions that we had trained observers document at that time. When we looked at flow disruptions per case, they were most profound in the operating room, specifically with the most critically injured patients. Flow disruptions per hour were noted to be higher in those most critically injured, but more often in the imaging suites and in the operating room. When we look at flow disruptions by hour and per phase and look at the clinical impact, you can see that these were most pronounced again in the imaging suite and in the operating room. When we look at Spearman's correlations between high impact and low impact flow disruptions, any value greater than 0.4 is considered a strong correlation. The reason that there was no correlation in the operating room was because of the small numbers of patients. And when we look at the most impactful flow disruptions by far in any phase of care, it had to do with coordination and communication. So the conclusions from this initial NIH-funded pilot study were that this was the largest direct observational study of the trauma process conducted at that time, 8 years ago. The complexities associated with the critical patient who arrives in the trauma bay lead to a high prevalence of flow disruptions related to breakdowns in coordination, most commonly, communication, equipment issues, and substandard environmental factors. Prospective observation allows individual hospitals to identify and analyze systemic deficiencies. And although a single flow disruption typically has little or no consequences, it indicates systemic deficiencies that may prevent delivery of optimal care. And so we felt as if we could streamline this process by actually implementing changes to the system. In 2014, a year later, we published this in the Journal of the American Medical Association, a human factors subsystems approach to trauma care. And essentially the objective here was to use human factors engineering to redesign the entire trauma process based on what we previously identified as impediments to care, namely coordination problems, communication failures, and equipment issues. This study used an interrupted time series design to collect historically controlled data, that's the data that I just presented to you, by way of a prospective direct observation. So we studied those patients at the Level 1 Trauma Center during the same time period in 2011, and then again after implementing these changes in 2012. So this was that follow-on study. A range of potential, so we had a think tank come together and create a range of potential solutions based on our observations. And we found that we thought the most promising interventions would be the use of headsets in the operating theater for people to be able to communicate directly one-on-one. Places for equipment storage that were accessible and standardizable. Medication packs that were standardized. Whiteboard use. Pre-briefing prior to performing the surgical pause. And training of the teams. So 5 of the 6 subsystem interventions were successfully deployed. Unfortunately, the communication headsets were found to be unsuitable in simulation. We had a simulation lab where we implemented the use of these noise canceling headsets, and it just didn't work. It became like the Tower of Babel. You had so many people communicating across these headsets that it just didn't work. Our main outcome measures, the primary outcome measure was flow disruptions with treatment time and length of stay as secondary outcome measures. Here's the design. So you can see that for direct observation versus site survey, we had all of these things that we wanted to implement across the bottom here that we thought would improve those outcome measures, length of stay, mortality. What we found, so you see the dark is pre-intervention and the light color is post-intervention, was that there was a significant improvement in the number of flow disruptions in the imaging suite where the CT scans were being performed, particularly in those high-level trauma activations. There was a significant change between pre-intervention and post-intervention in the emergency department in terms of flow disruptions by implementing these factors. And the risk of major mortality was decreased significantly versus the extreme mortality, which didn't change. Those who were extreme risk when they came in still had the same mortality risk, but in those who had a major risk of mortality, it was definitely statistically different. So this was the first study to objectively examine the effects of multiple subsystem interventions in trauma care and deployment of complex interventions based on detailed human factors engineering helped in terms of provision of trauma care and resulted in reduced flow disruptions, treatment time, and length of stay. So with that, I open it up to discussion. I know that this is an interesting period of research or an interesting group of papers, but hopefully it helps stimulate you to analyze your own flow disruptions and what could lead to better quality care. I would say that this is more like a Hawthorne effect. Once you shine light on something, all of a sudden it starts to, the quality starts to improve because you're paying attention to it. But this was a focused way of paying attention to flow disruptions. Thank you. Questions?
Thank you.
Yeah.
Immediate questions, but I had one. I was just, of those, the various kind of changes that you made, or that list of sort of interventions that you had, did you have any sort of evidence on what was most effective in improving kind of distractions and interruptions to your flow? Was there things that worked better than others?
Yeah, so it was mostly the communication. We did a lot of changes to communication, like whiteboard introductions, listing the attending surgeon on the whiteboard in the operating room, that sort of thing. It improved the channel and the flow of communication during those periods.
And were they sustainable as well? Like all of those new
yes,
things, are they still going? That's
a good question. Yeah, they are, and they're actually improving. I was part of this group for a brief period of time, but now at Cedars, they've implemented all kinds of, they actually have a simulation operating room that they're able to implement new changes to see if that impacts the quality of care. Yeah.
Team training, and one of the factors you talked about team training.
Team training.
Did you have the same, or does he have the same group of people conducting form care, or are they, transit? We have teams that, with registrars that come in for 6 months, go off, etc. How do you retain, I guess, the corporate knowledge of that project? I guess enlarging what Alice is asking. It's just the team training component. How do you conduct that?
Great question. So what we did with that information was we started to create protocols that are published in a central standardized repository where residents that are cycling through can see, okay, penetrating trauma to the neck. All right, here's the algorithm. And they can go through those algorithms and not have to repeat what everyone else has learned, as you say, when people are cycling through the team. And that's been very helpful because the residents now have it all right here. I don't know how many of you have been on rounds with the newer generation of medical students and registrars, but I actually was on teaching rounds and I asked a medical student a question and he pulls out his iPhone and I said, "What are you doing?" He goes, I'm looking up the answer to the question. I said, "That's not the purpose of this. I'm trying to test your knowledge." And he goes, "Yeah, but that's what I would do anyway." But I couldn't argue with him. I couldn't argue with him because that's where, we carry our computers around with us now. And you can look up the dosage of a medication. You can look up a pathway. You can say, okay, here's what we're going to do because, penetrating neck trauma, this is the patient's going to the CT scanner for a CTA. Okay. But these are ways to improve trauma care. And trauma is a rich environment to implement some of these measures. There's a lot of data flowing. There's a lot of laboratory data. And I think it's a unique area of research.
Emily?
I'm an infectious disease physician, so a long way from the trauma realm, but I'm really interested in the concept of formal team training and where do you think we should integrate that very broadly into the medical education system? I guess what resonates with me is a lot of, when you do disaster response, often but you will have really robust team member training and you bring together a group of people that can be really successful because of that training.
Yes. So in the military, we call that team steps training.
Yeah.
And that was very impactful because you had someone who was at the head of the bed. Their job was to manage the airway, and that was typically the anesthesiologist. I mean, and you guys do this in trauma care, but there were defined roles of each individual, and you knew what your job was. Your job, if the patient needed a chest tube on the left side, you put the chest tube in on the left side. If the patient needed a central line, someone was responsible for that part of the resuscitation of the patient. It's just like the Formula One example. People swarm in, they swarm out, and the patient is cared for. But that team training is essential, and it's I think it should. The problem is, and like Peter pointed out, is that you have this institutional memory, and then you have a new team, and they're not familiar with one another, and so it has to be repetitive. It has to be continual, and on a standardized. It has to be standardized, but it also has to be on a routine basis to familiarize people. Especially if you have a new member of the team leader needs to take that person aside and say, okay, here are your responsibilities for this particular patient. And it's all about communication, coordination.
Dan Dennis is online, wants to ask a question, and just listen to the microphone, it's not working.
Hi, Ben. Can you hear me?
Yes,
Oh.
we can hear you now, Dan.
Great, thanks. Great to hear you talk again, Ben. Sorry we're not in the room. My previous meeting overran by 5 minutes and I dared not walk in late after yesterday's presentation. So I decided to join remotely. But really interesting from a trauma perspective, and I think those in the online and those in the room who attend level 1 trauma calls at our institution will widely recognize the flow disruptions and the problems that you allude to. We do have those in our institution with frequency, and it does affect performance as well. But there's 2 areas just wanted, if you could just comment on, how in your studies did the differing team leader how much influence did the team leader have over the flow disruptions? In other words, did an excellent team leader who was able to control the room suffer less flow disruptions than perhaps a leader who was perhaps had a more quiet approach, and did that affect the flow disruptions, the quality of the leader? And secondly, just touch upon maybe the concept of flash teams in emergency and in this institution with so many doctors coming through the system so quickly. We find that many of our trauma calls are in fact a flash team event. The team's never been together before, and arguably might not be again together in the same dynamic for quite some time. So we're essentially running brand new flash teams every single time. I just wondered if you could comment on that as well. Thank you.
Yes, thank you, Dan. Interestingly enough, there was a difference between team leaders. So there were experienced trauma surgeons who would run codes very efficiently because they've been doing it for decades. And then there were some younger attending trauma surgeons who got a little bit excitable, and there were communication errors. So we did see a difference between leaders in flow disruptions, and there were less flow disruptions with the senior trauma attendings and more with the junior trauma attendings. So it was, and that plays into your next question, which was about the cycling of all of these teams and how can you maintain this quality when you have so many people coming in and out, and it's like a brand new team every time. I think we need to leverage our current technology to that. This was done many years ago, as you know, when we would videotape every trauma code and go back and look at it and say, okay, here's a guy that's just walking around aimlessly in this video from the ceiling camera. What is this person doing? And you would call that person out and say, what were you doing? What was your role in the team? We don't do that as well as we could. And I would submit, and we talked a little bit about this last night, Dan, at the dinner, and that is in the military, after every single code in Iraq, after every single mass casualty, we had an after action report, an AAR, and I was responsible as the operating surgeon for writing those up. But we would go around the room and we would go to every single individual. Didn't matter who they were. They could have been the person that was drawing the labs or running the labs. It could be anyone on the team. It didn't have to be a doctor or a nurse. And we would say, what went right in your mind and what went wrong? And how can we make this better? And you wouldn't believe some of the responses that you would get. You would have one of the janitorial staff say, I didn't have that towel that I needed. And you would never even think that that was an issue, but for them, it was the biggest issue in taking care of that patient, to have a towel to wipe up some of the mess. And so, you know, I think as team members, we learn from every single case, and that's the responsibility of the team leader after every single case. We don't do a debrief after every single case as well as we could. And I think that's something that should be implemented and everyone learns from it. And I'm looking forward to attending the trauma rounds tomorrow with you, Dan. Other questions? I know that this was a brief presentation, but it generates a lot of ideas in your mind as to, well, we could probably be a little bit more efficient in the way that we render care to our patients, especially trauma patients.
You can go.
Ben, I think you obviously discussed this. You visited our hospital. We're a civilian organization, so there are certain things. I guess in your team, you talked about clarity of role. What about the accountability piece? I presume I know from discussions with you that in the military you're accountable for your role. Failure to perform your role carries consequences.
Mm-hmm.
In a civilian organization, that's not so much of an issue. How do you manage that in terms of managing trauma and harm, or in fact any systems in harm? How do you incorporate that accountability in a civilian organization, in a civilian context?
I'm just, sorry, going to try and briefly summarise your question just for those online. So it was a question around translating this to the civilian organisation and in creating a way of having accountability for each of those roles.
Right. Well, I think that's a very complex question, but it has a pretty easy answer, and that is that all of our residents and all of our team members get periodic evaluations. And it's the responsibility of the team leader to give positive or negative feedback to the team members. I gave this example last night, and the example was about SEAL teams. They go to basic underwater dive training or BUD school, the Navy SEALs. And a few years ago, they looked at 6 different SEAL teams, and they asked those teams to accomplish an objective. It could have been to traverse an estuary or some objective. And what they found over and over again is that the same team would win the exercise, and the same team would have the least performing performance in that exercise. So then they said, okay, well, let's rearrange this. Let's take the leader from the worst performing and put him on the best team, and take the leader from the winning team and put him on as leader of the other team, the least performing team. And what do you think happened? The team that had the winning leader won, and that was on the worst performing team previously. So what that teaches you is that there are no bad teams, only bad leaders. And that's the hard thing for leaders to understand, is that it takes humility to understand that if my team's not functioning, it's my fault. I'm a bad leader. I'm not leading this team effectively. And that was proven in that simple exercise. And so that's an example of leadership. And I think that in the end, the leader is the person that is most accountable to what happens with that patient. And that leader is responsible for training up every single team member to treat that patient. You know, I learned that in the military. It's driven into you, which is you're not that special as a leader. We can replace you like that. We have to be able to replace you. If you are killed, your team needs to be able to continue to function. And so my job when I was on deployments was to make sure every one of my team members was at their maximum potential. Because what if, God forbid, I was blown up by a mortar round? I would want my team to come to my rescue and do what I wanted them to do, which was to save my life. And I couldn't do that if everybody wasn't functioning at a very high level. It's the team leader's responsibility.
Yeah, sorry. Thanks, Ben. That's great. Just a question. Often in a less acute situation, and perhaps trauma is when we're reviewing patients on the wards, and one of the biggest flow disruptions is accessing the electronic medical record. I don't know if you have the same challenges at your institution, but finding a computer that works with battery charge seems to be this major challenge for us. I just wondered if you had any great ideas that you implemented at your institution to overcome that.
Oh, we have the same problems.
Sorry, I'm going to
Trust me.
try and summarise
yeah.
Emily's comment / question. So the comment around we often encounter a lot of flow disruptions in our usual ward work, particularly related to the electronic medical record. And the question to you, Ben, was, I guess, whether you could have any strategies that you've implemented that have helped.
Yeah, and the answer is we have the same problems. So if our PAC system, our picture archiving computer system, goes down, that paralyzes everyone. I mean, because you don't have access to the imaging. You can't see the patient's images, or if it slows down and you're trying to get rapid reading of a CT scan, it could potentially be life-saving in the case of a type A dissection or something. But we're only as good as our weakest link, is what I would say. And so there are always going to be improvements in technology, but that is a factor. And we didn't specifically look at that. Let me go back to that one slide that we looked at here, right here. So there are environmental disruptions. So disruptions affecting the auditory or visual status of the operating room and not directly relevant to the treatment of the patient. And an example would be the X-ray tech had difficulty getting the X-ray machine into the operating room, or equipment problems, the monitors malfunctioning. Yeah, so these factors are all measurable. That's the whole point, is that we can measure these factors and then have a team of people say, yep, that's a flow disruption, that's a flow disruption, and then we can go back and look at it and change it moving forward. I know it's an interesting topic to think about, but we tried to wrestle that to the ground, and I think we did a decent job of doing that.
That was going to be my comment as well, was I think we've all had that same kind of feeling of, oh, this would save me many hours in a day and I would be more efficient and more kind of focused on my task if I wasn't thinking about this. I guess it's difficult the measuring of it is often sometimes a barrier in itself, isn't it? Or finding a way to accurately and objectively measure what those disruptions are, the Hawthorne effect, other things that come into play. I don't know if you've got any sort of suggestions practically about how, did you have a team of particular specialists who had training in human factors? And do you think that's sort of a necessity in the people who are measuring it, or can we sort of utilize different resources?
Well, I think if you have someone who's interested in human factors research, Doug Weigeman was a cardiothoracic surgeon, and his interest was in, a cardiac surgical procedure like an aortic valve replacement, open, or coronary artery bypass procedure. That is there are about 1,000 steps. And, dissecting down to, okay, why did this happen? Why was the proline handed to me in this way? And why did the needle break off of the proline? And, you can dissect down into very granular detail things that went on during the procedure that caused that procedure to be a little bit delayed or to have an untoward outcome. And I think by being able to measure the factors, you need someone who's going to be a champion in measuring this, or at least saying, okay, maybe it's somebody like Dan who looks at the trauma bay and says, okay, well, let's measure this. Let's look and see how we can make our processes better. I don't know. It's really interesting. I mean, this is a talk that actually made me think before giving it to you. Hopefully you'll be able to walk away and have more questions than answers.
We have Peter.
This is topic for us, all of us who conduct clinical work, clinical rounds, our heavy reliance on technology and our heavy reliance on each other and our junior staff being able to be accessible to us. One of the issues you mentioned is external interruptions. So in an operating case, we've talked about this before. There's not much that you're scrubbed in your office, but we've got junior staff that are helping us with ward rounds, responding to calls from the ward, etc. Now, we might not be in the acute environment of the trauma form, but as Henry is saying, then in the day-to-day matter, how do we measure and interpret how we can make improvements? I mean, the purpose of measuring it is so that we can conduct interventions. External interruptions, we all have it too, but you identified that the resident multitask. I don't know how many of our CMOs online, but I'm sure they can relate to it and show duties and yours come in as well. We ask them to do a lot, and we give them the ability, or we all have the ability to automatically be accessible. When in fact, the focus might be somewhere else.
Right. So we implemented a strat. Oh, did you want to repeat that question?
I can try.
Yeah.
So it was a question around the sort of, I guess, again, outside of the acute setting, where particularly our junior staff are often very interrupted and very trying to do multiple things at the same time, and that there is an issue with their attention between, I guess, of needing to be contactable and immediately available, but also that distracts you from what you're actually trying to do, and maybe you don't always need to be immediately interrupted, and how we balance that.
Yeah, so at Harborview, we had that problem. So we would have a chief resident in a case and his beeper's going off, and the circulating nurse would answer the page and say, there's a patient in the ER with a traumatic amputation of the leg. And there's this exchange between the circulating nurse and the resident. during the operation, and that was too disruptive. So we created what was called a hot pager. And that hot pager is one that would be the central number to call for a vascular surgery consultation. But that would get traded off at the beginning of the case so that the resident that was operating had no way of being contacted because someone else was carrying that pager. When that pager went off, someone was there to answer it. And I think that is a very simple solution to a complex matter. We all try to be available, but even when I scrub into the operating room, I put my phone on do not disturb because I'm not available. And I don't want to be called by someone about a consult when I'm not available and it disrupts my flow.
Role-based messaging, which I'm not sure we're
Yeah.
at yet, but we're getting closer, hopefully. Yeah. Thank you. I don't know if there's any other questions in the room or online. Also mindful if anyone has any questions for Carolyn around the pharmacy initiative as well. I didn't have a question so much as just a comment that obviously we're very, very excited to have you working with us in general medicine. And I think we'd be all very keen to hear any kind of follow-up as well. So I know that we're not starting it for another month or so, but that really keen to, I guess, have you back as well to see where you think we've landed in terms of our outcomes after intervening. And alongside the idea as well, I'm often trying to figure out a way to measure how long it takes our trainees to do certain things. That often when they're interacting with the EMR, and one of them is the time it takes them to complete an admission in the emergency department. Anecdotally, it takes a lot longer than when I used to do them. And so it'll be really interesting to see the impact of that, I think, on that task that they're trying to achieve and whether or not we can actually reduce some of that time to back, because we've added on so many things over the years. It would be nice to see if we can pull it back a little bit. So keen to try and measure that.
Just one more comment. Are you guys familiar with Epic at all? That's kind of the standardized electronic health medical record in the United States. Everybody, all the hospitals are moving toward using Epic. And what Epic has is a really unique dashboard, and it's a personalized dashboard that keeps track of certain metrics, and that is time to chart completion, how much time you've spent with patients. It even documents first case starts. So our metric is we want to start our case within 10 minutes of the scheduled time procedure. Now, some of you may laugh at that because that is a high bar to achieve, starting your case within 10 minutes of the time that it was scheduled to be. And it will tell you first case starts, what percentage. The first thing that comes up on that record is your dashboard, and it gives you your performance metrics, how many patients you've seen in clinic, how many operations you've done, et cetera, et cetera. So I don't know if you have something like that, that is a dashboard, so to speak, for each individual provider. It might be something helpful.
Yeah, I'm by no means an EMR expert. I definitely don't think we've got it to the level of the clinician. Peter may be able to train more. We have got certain things that we pull out of it, though.
So for certain things, we have something called system view that will give us some information regarding data utilization, delayed starts, and so on. But oftentimes that data, again, it's how we use the data. We need an intervention to ensure that the data isn't just an articulation of a problem. But it's interesting that you have an enterprise EMR across the whole, because you can benchmark half of you against Mayo versus, and I think that element would be very useful for us in real time.
Yeah.
Yes, I think we've put a lot into Sunrise in terms of information, and it would be nice to be able, we're not great at how we utilize what it could give back to us in terms of data and measuring our performance.
Is your electronic health record, is that national?
No, it's
No.
enterprise within our state.
You probably know it. We bought it as billing software from the US.
Yeah.
Billing software.
Yeah. So it's an enterprise level, but within our state, and Emily's correct. It actually started off as an administrative
Database.
It was an administrative tool, and then the clinical components were kind of, introduced into it. It's cost us a lot of money.
Yeah.
And is, I guess, what we have now.
Yeah. So you can't compare yourselves with people from New South Wales or
Not on this
Tasmania.
We have a program, but we have we subscribe to something called a health round table, which allows us to look at things like hospital-acquired complications. It's similar size, but they're not operational metrics. They're really outcome metrics and lengths of stays and so on.
Yeah.
And again, that's often data that we get
After. Yeah.
And I'm not quite sure how we can use that data to develop and improve the process.
Yes.
Great.
We could talk about Sunrise probably for a long time, but we'll leave it there. Thank you so much for your
Yeah,
time today.
thank you.
Thank Carol
Appreciate
again.
it. Thank you for coming.